in terms of AI systems, we talk, usually there are these three terms that are thrown around. Artificial intelligence, which is what we are usually most exposed to, machine learning and deep learning, which are more technical terms. But just to define as to what these terms mean, and I'm not an expert in this field, but I understand the fact about these three terms being, if you look at artificial intelligence, it's engineering intelligent machines and programs is the very basis for the AI systems. And machine learning goes into the ability of machines to learn without being explicitly programmed. So it can actually try to make decisions based on whatever information that it has. But deep learning, which is even deeper, allows machines to train themselves to perform certain tasks. So these are three, in a way, three levels of AI systems. And the deep learning is obviously, because of the term itself, but it's probably the most intense aspect of artificial intelligence. But more importantly than that is AI systems are constantly learning. And this is where I would like to ask a question to Simón, that, we talk about the fact that AI systems are learning as they go along. So one of the concerns that I have as a clinician is that would it mean, in a good way, would it mean that AI systems will be better as they work, see more and more patients in terms of screening, or why improvement with time? Why do we call it as improvement time? So Simón, would you take that question, please?
Yeah, sure. I think that is a very good point, and one of the big strengths of artificial intelligence is the ability to learn over time and get better and better as we continue training the system. This is where sometimes the regulatory aspects can maybe slow down some of that development, because, for example, right now the FDA, when they approve a system, it has to be fixed in time. They are wanting to put a framework of how they are going to approve systems, but that is still a work in progress. But definitely, the more disease we can see, the more retinopathy, the better the system is going to get. And the question is, how can we make sure that we improve as we go on time, but that we also don't introduce things that may be an offshoot of what we're trying to do. So
there are people who still, even today, talk about the fact that AI systems might take up their jobs, might take away their jobs, especially from an ophthalmologist perspective. We have time and again tried to explain the narrative that it is not. There are ways and means in which AI systems can play a part in the clinic. But Simón, it would be good to hear your thoughts about that as to how do you address, and I'm sure these questions keep coming up to you as well.
Right, and I think that is a very important point to make. I think people, even in the ophthalmology community that understand artificial intelligence and what it does, they know that it's not going to take away their jobs. That is going to help them see more patients, because about 80% of diabetics don't have a level of disease that need to see a specialist. So specialists, an ophthalmologist or a retina specialist, can dedicate more of their time to treating the sicker patients, or the patients who need either surgery or injections or laser treatment. But we have to think that there's still only a small percentage, relatively, of medical doctors who are very aware of what artificial intelligence can do for them. So there's a lot of education to be done there, and making the point that we're not trying to take away jobs, that this is about helping doctors manage their workload better, but we also want to provide better access, because we all know that there's not enough specialists for the amount of people that need to be screened for eye conditions, not in the United States, and much less in the developing world, because the amount of ophthalmologists per 100,000 in countries like in South America and Africa is very small compared to what it would be in the US or in Europe.
I think fails in a way, because being told but not being treated is psychologically difficult for a patient to kind of understand and accept. So what we have done is, and as Simón mentioned, we have decided that if you can put in a place where technology can help us screen patients. So we go into an area, we screen patients who come in or who are we reach out to earlier, and we find I have a disease that needs to be had a second look at from a human perspective, from a retina specialist perspective, we keep those patients aside, and then the person, a retina specialist who's tasked to do that, comes into that area, looks at those patients who are standard of examination, and then followed by, like you said, the person is carrying a portable laser right there. So idea being that especially in underserved not want to come back again. So if they come for interaction the first day and we ask them to come 4 or 5 days or 10 days down the line, they will never show up again. So we miss out on a chance of treating those patients. And so we tend to do everything on the same day. That's an important requisite in terms of intervention. And secondly, more importantly, from areas that we are dealing with is that these people tend to have, for lack of any other word, they, for them, spending a day and getting all the treatment done is probably more effective than going out there and coming back again and losing another day's wages. That's another problem. And the third thing is, loss of care, because like I said earlier, if those patients go away, they never show up. And why do we do laser? Somebody might have an objection. Is primarily again because of that, because patients do not tend to come back again. And so doing injections requires, first of all, things like OCT machine, which there's a lack of, and secondly, lack of patient follow-up. So, and those are the reasons why laser, even though it may be more damaging in terms of retina, but it does effectively, and it has shown in multiple studies that it is equally effective as compared to any other modality of treatment in trying to stop the disease from progressing further.
Right, and I last year when we were at the Pan American Academy of Ophthalmology, there were several talks on what's the the best treatment for diabetic retinopathy, and maybe from the evidence, injections is better, but effectiveness in places where you may not have a shot to see the patient in in a long time, laser for that is better. So I think it's a very interesting point, in particular when we're talking about developing countries and people who may be in rural locations or in areas where they don't have good access to the treatment.
I think those are the challenges we'll face. So Simón, one question for you is obviously about bias. How, when you develop the system, do you keep all these parameters in mind as you develop the system? And also, how do you try and prevent bias from happening?
Right. So the bias is a very good question and a difficult question to answer. As we were talking the other day, most of the systems have been trained with data from people who have access to healthcare systems. So there's already an implicit bias in that, because of there may be people who are of a higher socioeconomic level, and because of that they have a different color racial profile. So training a system that has been or using a system that has been trained in mostly white Caucasian people and taking it to Mexico, to Bolivia when we did the study in Bolivia, or to Africa. In terms of the training of the AI, we have to add robustness. We have to add as much data as possible that can represent the different groups where this is going to be used. And this is part of the AI learning, as we mentioned. And also try to develop from the AI side techniques that can basically put every image in the same level, so that we can, whether it's a dark pigmented retina or a bright pigmented retina, that after we do some processing of the image, that the neural networks that do the analysis in the end, see the same thing and can do the prediction. So image quality is another problem. When you train models in the lab, in data that has been collected with really good quality, that can also bias the system to only use images quality. And once you deploy it in the field and you see images captured by a technician that has very little training on maybe poor illumination, with patients who may have opacities, it is to try to give an accurate prediction. So you have to build that into your models so that you know how to deal with those issues and you're not having to reject 20-30% of the data or dilate every patient.
You also need to understand the fact that, how do you provide these devices and all the technology that comes along with it in these areas. Would you lease, would you buy, would you loan, would you give a grant, and what have you? So I think, Simón, if you have any thoughts on that.
Oh yeah, I have a lot of thoughts on that. I think this is also like so key because I've seen in my experience and in talking from people from all over the world that sustainability of the programs it's a big issue. What happens when we for example at VisionQuest we've done a lot of work that is grant funded, but what happens when that grant ends? And to create enough awareness in the local institutions and a sustainable business model as well for private practice doctors who want to provide these services. We have to keep in mind that outside of the U.S. charging more than $5 for an interpretation, it's considered completely unrealistic. Even less than that, we're talking in some countries, they're saying like it has to be $1 to do an interpretation. And when you look at how much an ophthalmologist, full dilated comprehensive eye exam would cost in India or in Peru, it's much less than what it would be here in the U.S. So if an ophthalmologist would do an exam for $10, you cannot be charging the same amount with AI. So it is an issue sometimes in trying to figure out what is the best way to provide this. And the other issue is the equipment, right? The capital equipment that you need to buy. A lot of countries have import tariffs that make a $10,000 to $15,000 tabletop camera be double the price in those countries. And in order for them to afford that and make it sustainable is really, really difficult. So having smaller, cheaper devices that can be portable so that you can take them to this, rural locations, it's an important thing that we need to have to really expand the reach of AI. Are we really developing the right kind of tools that the medical community needs, or are we trying to fit something that we already have into their current practice? Should we be talking to more ophthalmologists in different locations or more doctors in different countries to understand really what their needs are, whether it's the AI, the diagnostic right there, or is it much more that goes around it?
I think that's a brilliant question, and I think one of the biggest challenges that people who develop technology in terms of instrumentation and all that also have to deal with is you make this beautiful instrument, and it may not be applicable in terms of functionality in all the areas around the world. And so there's issue with power, there's issue with maintenance and all that stuff, so that comes into play. So in regards to AI systems, I think it is important, and I think that question really raises the point, is that if you plan to put this device, let's say in South America, in Africa, it makes sense to talk about first of all, to understand how screening is done, how patients are evaluated, and how treatment is provided.
And talk briefly about the study that we did together in Santa Cruz in Bolivia.
Sure. So, we were, Retina Global collaborated with VisionQuest in doing the study in Santa Cruz in Bolivia, which is also along with partnership from both optical, whose cameras were used. We managed to recruit about 1,000 patients within a gap of about almost 2 months. And we did get all the requisite, approvals from both ethics committees, as well as we reached out to the Ministry of Health in terms of getting an approval so that we could do a study as per international norms. We found, just to kind of highlight the fact that we found a significant amount of diabetic retinopathy in these areas. I would request Simón to talk about the results of this study, please. Simón?
Yes, thanks, Raj. And I think, like you said, the amount of sight retinal disease that was found in this population is much higher than what we will see, here in the U.S., for example. So that highlights the need of reaching out and having these programs to screen people who are out there with conditions that need treatment and they don't know it. The AI system actually had better sensitivity, which is surprising, but in a way not as much, because I've seen studies published to this end. However, we don't have as much specificity. When we compare the system, the AI system, with the iStar, with the retina specialist reads, we find a sensitivity of 92% and specificity of 83%, which I would say it's actually pretty good, because sometimes we're now used to seeing papers on AI and deep learning that have numbers that are over 95% and 90% specificity and so on. But that's when you take it into the field, they really perform, they don't perform as well as they did in the studies. So this is kind of the reality that you see in the field. This is one thing that we had expected to find, but we still can do a lot of good by detecting a lot of the patients that need referral without over referring too many people. What do you think AI companies like VisionQuest or others that are out there can do to better serve the physician community to solve problems that are important?
That's that's a very expansive question that you ask of me. I think if you look at both areas of developed countries as well as underdeveloped areas, there is significant need for services. So if there is a way in which technology can help reduce the strain on physicians and other people who are working eye care professionals, I think that will be a huge plus everywhere, anywhere in the world. To help people modulate their time so that they can provide services to who really need those services. Sitting with and as I mentioned, I think very early on in this conversation, that patients who do not have, and that's unfortunate reality, patients who do not have major disease, they are the ones who actually unfortunately take the most time. And this is what analysis has shown. So if there is a way in which we can reduce that time so that qualitative time of the physician or eye care professionals is given to patients who need it, I think that will be a huge plus. And that's where I think you guys come in. Apart from that, I think penetration is important. There are all these areas where there is no need, there is need for retina specialists, and there is no availability of any specialists out there. So if you guys can make a system that can potentially be used in a smartphone-based cameras or even a small handheld camera, and again, refer to the fact that internet systems, internet may be spotty in some areas, may not be available for certain periods of time during the day or night. I think that if there is a way in which images are read right away and responded back to within seconds or minutes, I think that will definitely improve healthcare provision and services to people out there.